Thank you for the introduction. Thank you for the opportunity to have me speak with you guys today. I wanted to start off by letting you know that unfortunately there are no why did the chicken cross the road jokes in this presentation, so I just want to burst that bubble right away. We're going to be just concentrating on gait speed. I have no disclosures, and we have several objectives today. First, I just wanted to briefly define short distance gait speed, go over which factors are influential in the gait speed measure, what clinical outcomes gait speed's been associated with, tell you a bit about the study that we performed about measuring gait speed in our chronic obstructive lung disease patients, and then how we implemented gait speed measurement into the outpatient practice. Some of you may have heard about gait speed in the past. It has been out in the news back in 2011, and this article from USA Today. There was a internet article about a year or so ago from a group here working on gait speed and Alzheimer's disease. So this has been out there. Just to define it a bit, really what we're talking about is just walking speed, and we're talking about walking speed over a short distance. We take the distance somebody travels divided by how much time it takes them, and then represented in meters per second, and that's the gait speed. Typically, we're really talking about a short distance here. It's about 2 meters to 20 meters that you're measuring, up to 30 meters in some studies. But this is the general range of what is used for gait speed. And again, it's represented in meters per second. Now, there have been several questions in previous publications about this topic. One of which being, how do we actually measure this? What's the proper way to measure this vital sign? And then what factors influence it? What clinical outcomes are associated with it? And how do we actually implement it into practice? And we'll hit on a lot of these. So in terms of how we should measure it, really the answer is it's all over the board. Different studies use different techniques when it comes to what timing mechanism they use, whether it's Stopwatch, whether it's an automated system. Gait, I believe, has been used in this institution in some areas. How you start the test. So do you have the patient already walking and walking into the course that you have, already in a moving motion, or do you have them in a static start where you measure with them having to accelerate through the course? Also the distance. Again, big range, 2 meters, 30 meters. Typically 4 meters or 10 meters are the most commonly used distances, but again, it varies study to study. So the other factor is really how you instruct the patient to walk. So you can tell them to walk at a comfortable natural pace, so that would be the usual pace there. You can ask them to walk as fast as they can, safely, and that would be the maximal pace. More frequently, studies have used the usual or comfortable pace, and typically encouragement really isn't provided during the test. It's a short, brief test. But again, there is variability there. Now, we do know that gait speed or walking speed is affected by several systems. Heart, lung systems are involved, joints, muscle strength, your sensation, proprioception, cognition are they all affect how we walk. And so one of the questions posed was, what are all the kind of patient factors that are associated with walking speed? This is a nice figure showing that age is a big factor. As we get older, from our teens into our 30s, our average walking speed goes up, and then once we hit 50s and 60s, it starts to slow down. It really drops off as we get older. Another factor looked at was cognition. So folks that have mild cognitive impairment walk slower than individuals with normal cognition. Individuals with mild to moderate Alzheimer's disease walk faster than those with severe Alzheimer's disease. So the severity of your cognitive impairment will also influence your gait speed. Mental health. Individuals with depression, schizophrenia, other mental health problems have been shown to have a slower walking speed than individuals without. So those are just a few. There's several other factors that have been looked at before. There's been several outcomes that have clinical outcomes that have been looked at in relationship with gait speed. And over time, they've been shown that gait speed is associated with mortality, activities of daily living, falls, hospitalizations, even hospital length of stay. And because of all these factors, it's thought that gait speed really should be considered and has been proposed another vital sign to implement in the clinical setting, just because it can give you a trend about, or a sense about all those factors. This is one of the big studies, most of you probably have been exposed to it, from Studensky and her group in 2011. This is from JAMA, where basically they pulled 9 cohort studies, almost 35,000 patients, and they followed them out for several years. And basically what they showed is as gait speed goes down, the predicted survival goes down as well. So for example, you have somebody who's age 70, if their gait speed is nice and fast at 1.6 meters per second, their expected survival is 25 years. But on the contrary, if it's slower, then their expected survival is 10 years. And the same holds true both for men and for women. This is a nice study showing gait speed and its association with activities of daily living. So here you have gait speed. As gait speed goes up, your likelihood of having ADL independence goes up as well. This is a study showing how gait speed is associated with hospitalizations, falls, nursing home placement. And really what we have here is 3 different groups. We have a very slow group, walking less than 0.7 meters per second. We have a normal walking group, walking faster than 1.1 meters per second, and in between. Basically what it shows is as gait speed slows down, the likelihood of having falls, hospitalizations, risk of nursing home placement all go up. And again, these are just a couple of the studies. There's several others linking all these outcomes with walking speed. And there's a nice figure put out in a paper by Fritz in 2009, and it's a nice summary paper of basically a lot of things that have been put out for gait speed. And it really goes over that, about 1 meter per second is a nice cutoff, where if somebody's walking at that speed or faster, they're probably going to do well, and they're less likely to have hospitalizations. They're more likely to be independent in their activities of daily living, less likely for adverse events, more likely to be discharged home. And then if you're at 0.8 or lower, especially 0.6 meters per second or slower, then the likelihood of all those negative outcomes increases. Now, whenever you kind of read through gait speed and pull all the literature, most of the time it's really been extensively studied in a healthy older population or in individuals with neurologic disease and some other cohorts, particularly MS, Parkinson's, Alzheimer's disease, but really few studies looking at gait speed in cardiopulmonary disease, and that was where our group comes in. One of our areas of interest is chronic obstructive lung disease, or COPD. It's a very common chronic disease that we treat on a regular basis. It's going to be either chronic bronchitis or emphysema. Again, very common. Millions of cases, both worldwide and in the U.S., and really it's the #1 reason for hospitalizations in the U.S. By 2020, it's expected to be the 5th most common disease worldwide. So again, this is a very prevalent disease process. And for COPD, we actually already have our own, we have a test that we use and have been using for many years. It's a marker of well-being and of basically all chronic lung disease, marker of functional exercise capacity and disease severity, and it's the 6-minute walk test. And I don't know how many of you have been exposed to that before, but basically a 6-minute walk test is just, we provide the patient 6 minutes to cover as much ground or as long of a distance as they can in that time. Typically, they start over in this cone. You have the administrator standing right here, and there's another cone standing here about 100 feet away. Typically, it's a 100-foot course, and the individual just does as many laps as they can in 6 minutes, and the distance that they walk is the outcome and is a marker of how well they're doing. This test has been around for decades and has been used widely in individuals with pulmonary disease and heart failure. It's used in our lung transplant allocation scores. It's used in our disease severity markers, disease severity scales for COPD, and has been linked with significant clinical outcomes. Just to give you an idea here, so 6-minute walk test where the patient is able to walk 400 meters or greater is considered a good walk. So they don't seem to have a lot of limitation. There's different cutoffs. But once you start getting into 300, especially 200, there is a limitation and an increased chance of mortality, hospitalizations, several other bad outcomes. The 6-minute walk test is really not performed routinely. It's done commonly. It's very frequently used in research studies. We do use it in a clinical setting for all the factors I just told you about, but it's really not done all the time and not on a basis where you perform it at every visit, because it does have a lot of time, space, and equipment requirements. You do need a very large corridor. You need to have the cones, timer. You are stressing somebody with expected cardiopulmonary disease, and so you need to be ready for the badness that will come with that. So crash cart, oxygen tank. You need to have a CPR certified personnel, and so all these are requirements from the American Thoracic Society guidelines on performing a 6-minute walk from 2002. So really, you need to have a fair bit of setup to have this happen. This is a test that you order on orders 97, just like an X-ray lab. They have to show up to either the lung function lab or cardiology department does it. And at the end of the day, we end up charging $590 for the walk. So again, there's a little bit more to it than just a 6-minute walk. And because of all those limitations, that's where we got interested in, let's look at something simpler, shorter, easier to use, like gait speed in our population, since there was a fair bit of similarity with the test that we already use. So our goal is really to develop a protocol on how to measure gait speed in our group that would work the best, evaluate how well gait speed is associated with 6-minute walk test in our group, since that's an important outcome that's already been proven, and then evaluate how feasible it is to implement this in our clinical practice. We started off by selecting patients out of our pulmonary function lab or out of our clinic with stable COPD. And we measured several factors. I'm just going to concentrate on the key ones. We had all the patients perform a 4-meter and a 10-meter gait speed walk at 2 different paces. First, they did it at a usual speed and then also at a maximal speed. So once we had them walk through at a comfortable natural pace, and then we had another two runs with a as fast as you can safely pace. And each time was measured with both handheld stopwatch that I used or our automated timer system. And so this is just to give you an idea of what the setup looks like. And basically the patient starts here, there's a cone right here, and they're given these instructions, and they start walking, and once they cross this path, the automated timer starts or the handheld stopwatch is started, and then once they cross this line, the automated timers stop, and the stopwatch is stopped, and again they have a deceleration zone. And again, we measured this distance both at 4 meters and at 10 meters. And then obviously we also then, on the same day, measured a 6-minute walking test on all of our patients to see the link between the two measures. So the most commonly used method to measure this is stopwatch. We did implement this. I was the one operating it for the entirety of the study. And then we needed to select an automated timing system when trying to compare the measures. There were a couple systems out there. Thanks to Nathan and Brian, we had a couple to review and compare. So down here we have the Brower system, which is a little bit more intricate, has a couple more kind of lap counting timers and so forth. And then here we have the Tractronic system. The Brower one runs about $900 to $1,000. The Tractronics one was $350 to $400. And when I played with these and just kind of saw how to use them in the simplest way, this one really came out as being the most feasible, just again cost-wise and just ease of use. Much less buttons, much less training on that system. And this is what it looked like. And this is what it still looks like in our back corridor. Basically, we have again our cone set up here. We have a emitter system and a receiver here. Same thing here, emitter, receiver, and another cone right there. So the patient starts here, and they're instructed to walk at a comfortable, natural pace, and they walk on through. And again, they're just timed from this point over to this point. And so the way that the system works is you have the emitter continuously sending a signal over to the receiver. And once this plane is broken between these two, that's when the timer, automated timer starts. And then when the plane here is broken, that's when it stops. And so basically your only output really is just the time that it took for them to walk that distance. And then when the patient starts to come back, it restarts again. So starts when this plane is broken and then stops when this plane is broken. And so just, again, just to give you an idea, all you have that comes out on this display is what time it took for them to walk between those two. We ended up enrolling 130 patients, more men than women. Almost all were Caucasian. You can see our cohort was older and overweight. The FEV1 here is forced expiratory volume in 1 second. It's our way of measuring the severity of their obstructive lung disease. So 50% is that cutoff between moderate and severe. And so this just shows that we had a nice blend between individuals with moderate and mild disease and individuals with severe and very severe disease. So we get a pretty nice range there. And you can see a fair bit of our folks were using supplemental oxygen. And the timers do have, you can program in a 2-second delay. That way, if they're rolling a oxygen tank with them, that won't trip the sensor twice. So there is a way to adjust for that. Here, I just wanted to show you the average walking speeds that we had. As you can see, again, about 1 meter per second is a pretty reasonable, it's a nice cutoff between doing okay and doing poorly. And our patients actually did pretty well. As you can see, for the usual speeds, they're about 1.1, 1.2 meters per second, and they were able to increase their speed when they were instructed to walk as fast as they could, up to 1.6, 1.7. And you can see there is variability between the different measurements, and I'll get into that a little bit more. First thing we want to do is really look at test-retest reliability. So for each measurement we did, we had the patient start from one cone, walk to the other, and then they came back. So basically we have a test and then we have a retest. And so what we measured is how different is the test-retest with all the different variables that we looked at. And the interclass correlation coefficients were very nice, so 1 is the best you can do. And here this just shows standard error of measure. So how far off will you be from one measurement to the other, and it's 0.05 meters per second. So there's really not a lot of difference between one pass to the other when they're done around the same time period. And here we wanted to look at the difference between using stopwatch and timer and how much variability you have between the different timing systems. So what this is just a Bland-Altman plot where all we're doing is we are showing what is the difference in meters per second in the one measurement that we got versus the other, and then plotting it over, what was the average gait speed during that, for that difference. And so if a dot falls right here, that means that there is no difference at all between the stopwatch measurement and the automated timer measurement. And if the dot falls right here, that means that the difference was 0.06 meters per second in the one measurement versus the other. The key here is that the mean difference was very small, and the 95% confidence interval for that range was also fairly small at 0.06 meters per second and minus 0.08 meters per second. So for usual, so when we tell them walk at a comfortable natural pace, measuring over 4 meters, we didn't have a lot of difference between the different timing systems. Although again, this is somebody who's doing this on a regular basis, just me doing the measurement. So if you start throwing in people that are less trained, you are going to have increased variability on that. Here we want to look at the same thing, except now with the maximal walking speed, where we have them walk as fast as they can safely. And you can see the range here is bigger, and overall you can tell that it really splays out once the gait speed's increased. So the faster people walk, the more variability we had between our timing systems. And we also measured very similar things with usual 4 meter and usual 10 meter, and saw that there was a significant difference between the different distances and what speed patients walked at, depending if it was a 4 meter distance or a 10 meter distance. So based on based on that analysis, we really thought gait speed is reliable from test to retest, no matter what kind of instructions we used, no matter what we did, but you really had to stick to one method. So you need to select out what's going to work best for your patient population, decide how you're going to use that, and then just stick to that. and you can't really vary, okay, this time I'm going to use automated timers, this time I'm going to use stopwatch, I'm going to use 10 meters, I'm going to use 4 meters. You're going to get variability, and you're not going to, as you follow this measurement out over time, that's going to affect it. That's going to affect that result. But if you stick with the same method, it was reliable. The next step of our study was really looking at the relationship between gait speed and 6-minute walk. We did this by looking at the Pearson correlation. And here, what I have down here on the bottom is 6-minute walk test distance. So starting from 100 meters all the way to 700. And here we have our gait speed measurement. And as you can see, as gait speed goes up, 6-minute walk test distance goes up as well. So if this was a perfect correlation, you would have all these dots fall along a single line right here, and the Pearson correlation would be 1. If it was a perfect negative correlation, the line would go this way. And as you can see, it's not a perfect correlation. There's a difference there, and our values fell around 0.8 for almost every measurement, slightly higher for the maximal than for the usual ones. The next thing we wanted to do was see gait speed's ability to predict specific outcomes that are important in our patient cohort. So for us, knowing that a patient's going to walk less than 200 meters on their 6-minute walk, or walk less than 350, these are key important findings. And so we basically generate a prediction model with just gait speed alone, looking at the ability of gait speed to predict a poor 6-minute walk test, so less than 350 meters, or a very poor 6-minute walk test with less than 200 meters. And the area under the curves were very good for those. And basically, area under the curve, one is it's a perfect prediction model where you can get it right every time. 0.5 is a flip of the coin. So the closer you are to 1, the better. And so these are pretty nice. Again, these are the numbers are small, so it may change a bit if you add on more patients, but pretty good initial results with that. So this is kind of now getting to more, probably what you're most interested in is, can we actually use this and implement it in our clinical setting? First thing we want to do is really look at patient acceptability. Will patients care that they're going to be asked to do one extra thing during their clinic visit, one more vital sign? And so initially what we did is I took 100 patients randomly selected out of our pulmonary clinic, and I, just as they were being roomed, I asked them if they wouldn't mind going and doing a quick 4-meter gait speed. And then after that I gave them a survey just to see their acceptability. After we did the patient acceptability portion of the study, we then went on into the clinical implementation, where we trained our clinical assistants to set up the timers, to do everything, where I wasn't involved in the process at all. They would perform gait speed measurement as a routine vital sign for our COPD patients. So not all patients coming into our clinic, it's just those that have an indication of COPD. And then we would then measure, acceptability by our clinical assistants, how long it took to train them, how long it takes them to set it up, how much time is this adding to their day. I felt like we had two main options as far as how to approach, the measurement. The National Institute on Aging and NIH, they've put out a nice CD that's available online that goes through the short physical performance battery, and that includes how to perform a gait speed measure. So if you download this and look at it, it's free, it's online. It goes through in detail how to measure 4-meter gait speed. The issue here is just to watch this and see how to do it. It's 25 minutes of kind of figuring things out, just watching, let alone training how to properly, they use a stopwatch, how to properly time it, and to do those things with 12 to 15 clinical assistants. We thought was going to be a very difficult task. And so we already had a nice, easy setup that was ready to go. So even though this is out there, and I think is something that's a nice option, we decided to go with our more homegrown, easier to use system and see if that would be actually feasible in the clinic. For the patient acceptability part, again, we had 100 patients, and overall 99 out of 100 said that it was either very acceptable or acceptable. One patient said it was somewhat acceptable, but overall we had very little pushback from patients to say, no, this is not something I want to do. And as far as the clinical implementation part, this is right as you walk in from the waiting room into our department, we have a little room here where we do our weight, our height, our oxygen saturation measurement, our heart rate. And then the next step would be that the patient would be walked and roomed into their room in this corridor. But what we had the clinical assistant do was the patient would just walk over, they would drop off their belongings in this room, and they would keep walking down that hallway into the back hallway where we have our equipment all set up. Everything is ready to go. And basically we hit the power button on this, and that's the only thing that the clinical assistant has to do is hit power on the display. They measure the patient walking from here over to here, and then from here back, and they record the fastest walk. And then they room the patient back. This is the report that the clinical assistant provides to the physician. And basically, we just have the patient's name or label placed on there. And all that the clinical assistant has to do is put on what time was displayed out on the machine. Then the clinician just looks, okay, it took him 5.2 meters, 5.2 seconds. Let's take this, bring this over. Okay, their 6-minute walk distance is going to be roughly between 250 and 350. So again, this isn't going to be perfect, but at least gives you a ballpark idea of where is their exercise capacity, functional capacity going to fall. And then on the back side, obviously our staff aren't used to gait speed. This is not something that we do. So on the back side, I provided them with this, with again a way to both educate the clinician on what does this measurement mean, but also the patients. The patients come back going, you know, what was this? What does this mean? They know what a blood pressure value means. They know what a heart rate value means. They want to know, why did you measure this and what does it mean? And we've had good feedback as far as physicians being able to say, okay, well, you're in the nervous range. This is concerning, or you're doing just fine. For the clinical implementation part, we saw that it took about 3 to 5 minutes to train each person. So simply because the setup and the administration is so simple, it really didn't take much time, and we could group clinical assistants together when we did the training. So every morning, the equipment has to be set up. I have it all up here so you guys can just take a look and play with it. But we do break it down every night and then put it back up in the morning just to get it out of the hallway. And it takes 3 minutes plus minus 1 to set it up, depending on how quick the clinical assistant doing it is. And in terms of that extra time from walking past the room they would have been already roomed to do the gait speed and coming back, it adds an extra 1.5 minutes. So that's with the two passes, we added an average of 1.5 minutes to our rooming period. And then the response from our clinical assistants was really that the measurements were either very acceptable or acceptable, but at the same time, we're not measuring it on all of our patients. It's just our COPD patients. We're performing around 10 to 15 of these a day. So when we asked the secondary questions of, would you want to do this on all patients, the answer was no, and this is already, especially during there's peak rooming periods of 8 in the morning and 1:30, when it does cause a little bit of traffic jam, and because it's not every patient, then it's doable. And so we believe that it does need to be selected in terms of how to do this, especially if you just have one area where you're going to measure this. So in summary, we do think that we have a highly informative measure here. We think that it's associated with the 6-minute walk test well, and it is reliable as long as you stick to one method and just follow that through. And at the end of the day, we thought that the implementation was fairly easy with the use of the automated timers, and obviously depending on the workload on your staff and their technology savviness, all that varies. But in our department, it has worked out well, and we're continuing to do this even now. So I had to steal this. I'll have to set this all back up after lunch. 3 minutes. Yeah, so pretty soon. So I wanted to thank all the people that have been instrumental in this study. Dr. Benzo's my primary mentor, and then all the other individuals, including Nathan, Zach, everyone else involved. And then I have my email address here in case there's any other questions after this talk.